listening to Healthy Discussions, the podcast where we explore big issues and our guests' ideas about them. I'm your host, Zach Hassan, a junior doctor from Scotland. If you're interested in thinking critically about the world around us, then this is the podcast for you. My guest this week is Guen Bradbury, an innovation consultant for Inovia with a background in veterinary medicine. She also runs a vet tele-consultancy, teaches undergraduates at Jesus College, Cambridge, and is the author of the textbook Behavioural Problems in Rabbits. We talked about her overarching interest in how our modern artificial environments shape our development and physiology, and the science behind her work. I hope you enjoy. Gwen, welcome to the podcast.
Thank you very much, Zach. It's lovely to be here.
And it's lovely to have you. Being a vet and an innovation consultant, merging the corporate with the clinical, how did you end up doing that?
It's a great question, and it's one that everyone asks because it's not exactly the sort of career progression that I think I thought I would do when I left vet school. But I left vet school having done 6 years at Cambridge, having trained alongside medics, so having had a lot of exposure to both animal biology and human biology. And I left vet school. I did a couple of years in small animal practice in the Northwest. Then I moved to Edinburgh, where you are, as we were just talking about, and I worked in clinical anaesthesia for a couple of years. And then I wanted to change. I was looking for something which had a better quality of life, and that will certainly be, I'm sure, familiar to anyone who works in healthcare professions. I wanted a better quality of life, more interesting work, and more ability to make a difference. And so that's why I applied to Inovia Technology, and that was 6 or 7 years ago now, which is terrifying.
And what's the background about Inovia as a company? How long have they been around, and what sort of work do they do?
So they were founded 23 or 24 years ago, just a little startup. And the vision was to be able to provide help with innovation to very big companies. And I guess the first question that most people have is, well, why can't they do it themselves? They have so many people. They've got specialist knowledge of whatever area they're focusing in. Why can't they do it themselves? Now, the challenge is that when you innovate, when you're trying to create new products or new services, you need to think about things in a very different way. And that may mean that you need people with different backgrounds. So, for example, if you usually make joint replacements and implants, and you've got lots and lots of engineers, and you're trying to work out what the next step is, maybe you need biologists, maybe you need chemists to understand, how things interact in the body. So it's not efficient for companies to have all of those different skill sets in one place. And so that's part of it. They come to us because we have lots of different people with lots of different backgrounds. I work with medics, I work with chemists, designers, behavioural scientists, engineers, physicists, a great big group of us. But that's not all. The other thing that my company does is that we work with clients in lots of different sectors on innovation. So we work with clients in the energy sector, in food, in apparel, in shoes, in medical devices. And what we realise is, though the problems may be different, the kind of fundamental process of innovation is actually very similar. And problems can be solved with similar insights. And so that's the other reason they come to us, is that we are very skilled at innovating specifically. That sounds a little bit glib and a little bit corporate. Does it make sense?
No, it makes absolute sense. It's sounding to me like you have, as a vet, you have certain skills, you have a certain scientific understanding that is useful in the corporate world. But it sounds like in your clinical life, you weren't really getting to work on the same variety of problems that you're getting to work on now. Is that part of what influenced your jump outside of clinical?
Yeah, I think so. I think I have a huge diversity of different sorts of projects. So, I've told processed food companies why processed food is bad for you. I've told shoe companies why their shoes cause long-term foot pain. I've told, joint implant companies how you have populations that don't need joint implants. So I've had the pleasure of really exploring some of these problems in enormous amounts of detail, which is way beyond anything you can ever do in clinical practice. with the advantage of keeping that diversity. So actually you can go, right, so it's a foot and it's behaving in this way, which is actually quite similar to a spine in this respect, and it's different from a knee here. And so having that, being able to maintain that really broad view is just fascinating, Zach. I freaking love it.
Yeah. And what sort of are the problems that people are coming to you with in the corporate world? Are they different to the sorts of problems that people were coming to you, as a vet? I just wondered what similar skills do you get to use, and if you could tell us a little bit about that.
Yeah, absolutely. So, I mean, although we work in innovation, we're fundamentally consultants, and actually the consulting process is the same, whether your client is a representative of a multinational conglomerate, or whether they are, the owner of a pet in your consult room. You take a history, you do a full clinical examination, you work out your list of differentials, you work out what diagnostic tests you're going to perform. You think about treatment options, and then, because we're vets, we don't work in the NHS, you talk about prices, you talk about what's feasible, and then you go from there. So although our projects are on a much longer timescale than a typical consultation, that kind of fundamental process and those skills are very relevant no matter what form of consultancy you're in. So the consultancy part certainly has got very close links to being a vet. And because I'm a veterinary surgeon by background, I work on life sciences problems. So actually that is exactly what we're trying to do.
And it sounds quite fun that you get to actually try and work out what the answers to these different problems companies are having should be. It's, when I've been reading up about stuff that you've all already kind of said about how you do that job, it sounds like you have to go into the scientific evidence and really try to make sense of it in a way that other people are going to understand who maybe don't come from a scientific background. And what I think you've been saying online is that sometimes that's difficult because the scientific evidence isn't always out there for some of the questions which we're asking, and that can be quite frustrating. But can you tell us a little bit about how you go about that if the science doesn't seem to be clearly there?
Yeah, sometimes our clients come to us and the science is there, and it's a question of looking at the literature, looking at the current state of the evidence, and telling them what it is. That's great. That's fairly simple, but that's also often something that they can do. One of the challenges that they often come to us with is understanding why all bodies are having the same failure mode, but outside the sort of usual lens that we look at it through. So if I take an example of I don't know, let's think about osteoarthritis, because that's one that affects so many people, and we think that we know what is causing it and what people need to know differently. So there are lots and lots of, if you look online, don't run, don't jump, make sure that, keep doing kind of low levels of activity into old age. Doesn't really matter what you've done earlier.
People get told that it's about wear and tear, isn't it?
Yeah, absolutely. And then when you start looking at how cartilage nourishes itself, when you start looking at the mechanobiology of the different parts of that structure and the sort of loads that they need to bear, you actually start going, oh, hang on a moment. So this is not necessarily wear and tear. What's the role of childhood activity and development? What's the kind of standard that's being set there? What is the role for not just moving in the wrong way, but being still in the same way? How does that then affect how cartilage is nourishing itself? How do we end up in a state where our cartilage is just a bit sick? So if it does get hurt, we do get the kind of bigger injuries. And in order to kind of ask those questions, you need to not only look at lots of pieces of different evidence, but you also need to say, what is it fundamentally that our bodies, I'm putting inverted commas that you cannot see it on a podcast, what is it that our bodies expect? What are the sort of movements? How does our cartilage expect to have load distributed? What are the types of loads? And then you start to say, okay, so then, what is the role of shoes? What is the role of sedentary activity? What is the role of diet? How do you tie all of this together to see the bigger picture? And then that starts to give you different ways of solving the problem that might be slightly outside the way our culture puts constraints on our behaviour and, how we live. And that, to me, is when it gets really interesting, because actually there are all sorts of kind of biases and assumptions that we have, that when you start to challenge them and say, well, could you do this? How about that? You end up in a different place. You're asking different questions and you get to different solutions.
I was kind of wondering how you're going to link the scientific evidence to some of the cultural stuff which is going on. So things like, yes, how shoes affect our feet and our biomechanics and that sort of thing. Those are almost getting into sort of political and social science questions, which can be quite difficult to answer scientifically. My question is kind of, how do you go about trying to pin some of these mechanisms down scientifically? I wonder if you've got any examples that you've worked on where, you know, you're getting into some of those questions and being actually able to answer, well, what is the effect of shoes on our feet? You know, because that sounds like quite an interesting question that a lot of people want to know.
Yeah, absolutely. So let's think about shoes for a moment. So we had a client come to us and say, what is it, you know, how do we make shoes that are going to be comfortable in the long term? Because everyone knows what comfortable shoes feel like when you put them on, right? They're really comfortable, they're kind of squishy, they're supporting your feet feel like they're being hugged. You know, there are lots of reasons that you know what a shoe is comfortable in the short term. But what does that look like 6 months down the line? What does that look like 5 years down the line? What does that look like 10 years down the line? And what you start to see is that when feet move as a single block, the loads are referred up to the knee are then on a very small area of cartilage. That's the shoes move as a block. If you think about a heel on the shoe, like everyone has heels on the shoes, what does that do? How does that push your pelvis? What does that do to your knee? And suddenly you start to go, oh, right, so something that looks like a very small intervention, which is having shoes with, you know, that kind of, you know, slightly pointy toe and the little heel and the rigid sole. What in effect that is doing is putting smaller and smaller loads so bigger and bigger loads on a small area. Now, in a veterinary context, we're also lucky because some of our patients wear shoes, right? So our horses wear shoes. And so we're very familiar with how horse hoof anatomy changes when you put shoe on it, because the horse hoof is a very specialized structure. It's got all of these beautiful evolutionary adaptations. So as the horse puts its weight down, you get splay, you get impact absorption, but then you get elastic recoil to help the foot move off. It's important for venous return. You suddenly have got a structure that is really, really complex on the end of the leg. And I think sometimes as humans, we think that our feet, you know, really the only thing that they're doing is providing the link between the ground and the rest of our interesting body. But when you start to say, okay, so the foot is a very, very complex structure, what are the things that we are losing when we are outsourcing some of these movements to a device in which we put our feet? That's when you can start to say, okay, so what are the consequences of different, you know, there's actually quite a lot of information on how heels affect pelvic movement. And then you can say, okay, so what is it, what are different sorts of pelvic posture linked to? So, and then you can say, you know, how is running in these shoes versus these shoes affecting gait? And add that onto what I know about how the knee is behaving in these situations, you actually kind of get evidence from lots of different branches of science that might be looking at gait, it might be looking at performance, it might be looking at specifically foot pain. But you're sort of tying them together and saying, this is the bigger picture here, folks. And what I always find surprising is that often papers just cite other people in that discipline. And so the links for that really kind of multidisciplinary thinking are just not being made in the way that we do science frequently.
It sounds very exciting that you're getting to actually make some of those links. You've touched on a few things which I've recognized about academia, which make for not very good science. The fact that these are very tight fields, that there is a economic pressure to continue getting funding, to continue writing papers about the same sorts of things, but then losing that ability to work on lots of other problems which aren't necessarily getting funding, but you know, people are very interested in. For example, you know, what you're saying about shoes. There's this whole craze about barefoot running at the moment, and I've got some barefoot running shoes, but I have no idea in terms of the science. You know, does that actually help how I run or not?
One of the challenges with barefoot movement generally is that once we learn a small amount, we kind of think we've got it sorted. So we say, right, okay, so if we're currently wearing shoes and shoes are bad, and we now start wearing no shoes, everything is going to sort out. But one of the things that we often fail to recognise is the impact of lots of different pieces on that puzzle. And the fact that if you are a body where, I'm not making assumptions about you, Zach, but I'm presuming that, like most of us, you probably don't spend a lot of time squatting. You probably don't spend a lot of time sitting on the floor. You probably sleep on quite a comfortable mattress. You probably haven't done a lot of barefoot running before. Your feet are usually confined quite a lot in the shoes that you wear generally. So what we have is we then have a body that is not quite as nature intended. Let's be honest about it. And then when you then suddenly start going from very sort of supportive shoes to barefoot shoes, people often get injuries because they haven't transitioned and they don't recognise where the limitations are outside of outside of their running practice. And that's why if you look at the evidence and you look at the sort of scientific studies that have been conducted, a lot of them which find that barefoot running increases the rate of injuries, have very, very quick differences between these two states, either barefoot shoes or full supportive shoes, which makes science questions easy to answer. But actually, it doesn't recognise what bodies need in order to adapt. So my point with any of these kind of, big changes is that bodies take somewhere between 2 weeks and potentially 6 months to adapt to very serious new loads. And even if you only ever run in bare feet and you don't do a lot of walking in barefoot shoes, your feet may never get as strong as they need to be. Does that answer your question?
It absolutely does. And it's kind of clued me into this other thing which I've heard you say, which is about how the scientific evidence is biased in the sense that a lot of the scientific evidence that we've collected, which we think is about describing, the human body, is actually only describing the human body in a particular environment which we've actually created. So it's not the natural environment. When we're looking at whether people have flat feet or whether people have osteoarthritis or back pain, these are all problems of the modern environment. And it's very difficult to be able to study a human in some sort of natural environment that doesn't exist anymore.
Yeah.
Those questions about whether the scientific evidence base is actually biased is something that I know that you're interested in. Are there other things which we are getting wrong as scientists, as people interested in truth?
Mm-hmm.
And how does that play into the medical field specialties where we want to ask questions that actually make our patients' health better?
Mm-hmm. I think it's a really good question, and something that certainly when I went through vet school, evidence-based medicine, we were taught very much that was the gold standard. And so to then get to a point where you start to say, but what does the evidence base mean? Where is it applicable? Actually, that for a while was a very uncomfortable place to be. But what I've recognised is that there are certain things that are true about the evidence base and the context of the evidence base that if you don't consider them, you may inappropriately apply conclusions of the evidence base in your general life. And there are two real problems here. There is, if we think about right through history, a lot of our behaviour, well, almost I would say the entirety of our behaviour for a very long time, was certainly not evidence-based. It was anecdote-based. It was, who do you know? What have you seen? What is your own personal experience? And then there came a point at which people started to say, well, can we gather evidence? Can we learn about what is happening by applying the scientific method? Which is great. But one of the problems happens is if you've already had a major cultural shift that has affected our behaviour and through that our biology, before we started to gather evidence, then we don't understand that the questions that we're asking are wrong because they're completely framed by our cultural understanding.
And there's no control group that you can compare to, is there?
No, well, exactly. That is the question. And there are control groups. There are almost always control groups. But that brings in the other slightly uncomfortable truth about science, which is that it is very, very, very much it's very biased. And actually, we always have a tendency to think that we are special, and we exclude others because they're not us, they're not living in our culture, they can't possibly have input that is going to help us. And then you lay on top that racist belief that in some way, Western culture is the pinnacle of human evolution, and therefore we are living how we should live. And the problems that we have are not really related to decisions that have been made. It then makes it very hard for people to say, actually, let's look at people in Tanzania. Let's look at people in Guyana. Let's see what is different here and what is the same. People are starting to ask that now, but actually when the big questions were asked, when the scientific evidence gathering was asked, people did not look outside, typically the British Isles, if we're talking about British research. And that, again, leads to profound knowledge gaps. So there's a timing piece about what's happening in your culture, and there is a kind of cultural blindness piece to what you can learn from other cultures. And those two things can make some of the really founding precepts of a discipline actually quite shaky.
And what do you think that we should do about that? Because if we accept that knowledge gaps are a problem, is the answer to do more science, or to do it better, or to try and do it in a culturally neutral sort of way? Is that kind of the lines along which you're thinking?
So that's a really good question, Zach. And I have to say that I think that the solutions look different in different fields. I think the one that stands out to me at the moment, and it's one that I've talked about before, is around our understanding of reproduction and birth, and which is very much defined by our understanding of reproduction and birth in our culture. Now, one of the challenges here, and I'm sure you've heard this before, Zach, but there are a lot of environmental determinants of how mammals give birth. Mammals typically look for the same sort of things when they're wanting to give birth. They want to be in a warm, dark, quiet, familiar place, either alone or with familiar people. And as a doctor, and I'm sure you've seen labour wards and you've seen delivery suites, this is not met in the way that we get women to give birth in our culture. And
I'm trying to think of an environment that is further from from that, and I'm thinking, you can't get much brighter and chaotic and lots of things going on as in a hospital, and especially a maternity ward.
Yeah, especially in the state that they're in at the moment, which is very busy and very underfunded. So then we have a problem where there are enormously high medical intervention rates. There's 30 to 40% caesarean sections, 1 in 3 labours is induced. We have very high rates of postpartum hemorrhage, of episiotomy, of perineal tears. We've got lots of severe consequences for maternal and neonatal morbidity, and certainly in terms of mortality, it's actually not really very much better. So most of the specialties have seen amazing gains in survival, in patient outcomes in the last 30 years, but not obstetrics. It really has stalled, and that's quite a confronting place to be, because if I think back to when my mum was giving birth to me, I would hope that we were in a better place now. I would expect that. So if we think about what has happened specifically in the birth world related to what I've just mentioned, we started to alter quite a lot of factors around birth because we had views about what should happen. And I'm sure you'll have been taught at medical school about rates of puerperal fever, of doctors transmitting infectious disease, because they didn't realise that infectious disease could be a problem. And that's just one of the kind of examples of, the blindness that we all have when we don't understand something. But in the medical world, for a long time, everyone gave birth at home. And there are definitely cons to giving birth at home if you do not have a good medical system to go into if something is wrong. But it also very much fits with the physiology of a labouring mammal, because you are in a very familiar, very safe place. And what happened in the 1970s was that there was the publication of this report called the Peel Report, which said that hospitals should be able to provide places for all women in labour. And because it was believed it was safer. Unfortunately, this wasn't the case, and this was highlighted by Marjorie Chu, who was a prominent statistician at the time, and one of the most prominent outspoken advocates was Archie Cochrane, who gave his name to the Cochrane database, of evidence-based medicine. He realised that this report was not founded on fact. And now we are, 50 years down the line, we are currently at a place we've never had more intervention in childbirth, and it's still not getting safer. And that really suggests that we need to think about rewriting everything that we do. So what would I do if I was trying to rewrite a whole medical system to be more in line with biology? Well, fundamentally, I'd respect what labouring people need, which are those core things: familiarity, warm, dark, safe place, either alone or with a familiar other. Ideally, I'd like to have an other in most birth situations, because if things go wrong, you want to have someone there who knows what they're doing. But that person needs to be familiar. And that's when we end up thinking about continuity of care models, so having the same provider right through and the same provider at your birth. That's when we think about moving birth, almost all birth, out of the hospital and having the hospital close by. We have ambulances, we have people to get people to hospital. And then having a hospital that is helping the people who really need help. And once you're only helping the people who really need help in a hospital, you end up with intervention rates being directed specifically at people who need them. You end up with people who are in the hospital not being overwhelmed by a flood of people who don't really need medical intervention, but who do once they've gone through the process that you put them through. And you end up hopefully being able to provide better healthcare in a more cost-effective way with much less maternal and neonatal suffering.
So your argument about trying to take birth outside the hospital, it's not about being anti-intervention. It's about trying to say, well, if we understood physiology a little bit better, then we might be able to create environments where, which are more likely to make birth happen without those complications arising. And that's very interesting to me, because if it is true that we've created an unnatural environment that is stressful for people to give birth in, and that is contributing, it's very clear to me that we don't really consider that as clinicians on a day-to-day basis. The thinking of a clinician is very much, what are the risk factors that suggest that this person is going to need a cesarean section, and then trying to do that. And we've seen from the Ockeden Report how if we get those decisions wrong, the consequences can be quite tragic. So if there is a way of trying to sort of square that circle so that you're reducing the amount of interventions that you need, but actually not avoiding those consequences, that seems to me to be a good thing. Do you think that that's possible?
Let's just talk about the Ockeden Report for a moment, because I think that is one that will be on the forefront of many of your listeners' minds, especially as it's been reported in the media, which is that a focus on natural childbirth, i.e. vaginal birth, has put lots of women at risk, and many women and babies have died because of this erroneous, aspirational belief. The problem is that what it reflects is there's a fundamental understanding of what kind of a physiological birth is. In healthcare, because everything is about outcomes, we forget that just because a baby emerges through your vagina doesn't mean that that's physiological in any way. And defining it solely by defining cesarean sections as the problem and as a non-natural childbirth that should be restricted in access to meet to prevent having financial penalties for high cesarean section rates, just reflects a fundamental misunderstanding about physiological birth. For me, it's the same argument. If you're going to try and reduce the number of cesarean sections by preventing access to cesarean sections, it's as catastrophic as trying to reduce abortions by restricting access to abortion, to pick a very topical example. Yeah. When people need them, it's too late. So actually what you need to do is, if you actually want to reduce those outcomes, you need to intervene so much earlier, whether that's providing right information, providing right care, or creating the necessary social support. Trying to affect something at the point it's happening doesn't work.
What's interesting about your argument is that a lot of people focus on the physiology first and then try to predict, okay, who's going to need intervention? How is that going to affect what the outcome is? You're actually looking at the environment and saying, well, what are we doing wrong in terms of how we set up the environment that is having an effect on the physiology behind this problem? And can you explain a little bit about the mechanisms by which the environment can influence our physiology? Because that's not something that is immediately obvious to people, but it's something that we both know from our studies that stressful environments, there's this constant interaction between your body's homeostatic mechanisms and then what you're experiencing in the world. And anyone who's been in a stressful situation at work will just know, if they've made a bad decision under pressure, that's the effect of environment on your own biology, in one way. What other mechanisms do you know about are prominent in your work?
Sure. So if I'm a vet, I've seen a lot of animals give birth. I've seen, sheep, cattle, horses, dogs, cats. The vast majority of our veterinary patients give birth without any problem whatsoever, without any, usually without any outward signs of suffering or distress. Now, what has to happen for labour to occur is that at the beginning, you've basically got this interplay of four hormones. You've got oxytocin, beta endorphin, adrenaline, and prolactin. And I'm not going to go into details about all of them, but I'm going to specifically look at adrenaline because that is the one that we can really screw with. So in order for labour to really get started, we need to have a really low adrenaline, which persists throughout the initial early contractions, the contractions that ramp up. And then at the point where the baby is about to move through the cervix and descend through the birth canal, you get this big spike of adrenaline that helps to clear some of the rest of the hormonal fog, so you're very ready to meet your baby. Now, if you've got high rates of adrenaline in the first part of labour, adrenaline is a fight and flight hormone, as you're well aware. High rates of adrenaline impair the oxytocin waves that are needed to drive the contractions. What does that mean? It means that you end up, if you stress out an animal in the early stages of labour, they can decide that now is not the right time to pop out a baby. So if you go in and you mess with a mare who is in early stage labour, she can just stop everything for a couple of days. When that happens, I don't think, oh my goodness, look at this mare. She's clearly got failure to progress. There is something wrong with her body that is not allowing this foal to be born. No, I think, crap, what have I done? Like, how have I screwed this up? I just need to wait and see. And if we think about the sort of descriptions of women that not all women, but a lot of women in hospitals, they will go in feeling like things are really, really cracking on. They'll get in, they'll potentially be examined. So having someone, looking up inside you, telling you where you're at in a very bright place with lots of unfamiliar people where you're really scared because you're associated with hospitals. What does that do to adrenaline? Absolutely through the roof. So not only does the adrenaline clear all of the beta endorphins that are there to help you cope with the pain of contraction, so suddenly the contractions are really bloody awful, also it prevents you having the difference in that spike. So you've got suddenly all of your hormones are out of whack, and that normal labouring process does not proceed as it should. And potentially, with enough time, if people are calm, things may settle down. But I can't even tell you that because we're now in a pathological place rather than a physiological one.
Has that mechanism been described in humans as well, of being able to halt labour? Or is this another one of those problems where we don't really know because we haven't had that environment and been able to study it in enough numbers to come to a conclusion about it?
That is a good question. I can't tell you the names of studies that have done this, but certainly the hormonal mechanisms involved in birth are very well established. I suspect it has been done. I'd be very surprised if it hasn't, because there's so much literature about this in animals. It would be very surprising if people had not also looked in humans. But certainly anecdotally, you will find plenty of doctors, plenty of obstetricians who are aware of normal physiology who do talk about this.
Well, I'm going to look forward to if there's any comments about, you didn't talk about this paper, so I look forward to that.
Me too.
So maybe we'll both learn something. But it also seems to me that this is part of a bigger problem in healthcare, in underserving and a lack of knowledge about women's health specifically. There's been quite a famous book written recently by Caroline Criado
Yeah,
Perez
Criado
about
Perez. Yeah, Invisible Women.
Invisible Women.
Mm-hmm.
And she is making the point that the evidence base is very biased against women, because who do we study in the medical profession?
Mm-hmm.
We use healthy male young volunteers, and that's great for some problems, but obviously not for studying pregnancy.
There's certainly very strong beliefs. I mean, even when we go back to, religious beliefs around, in suffering shall you bear forth children, even the translation of the religious texts are biased by who translates them. And so actually, if you look at even the words that are used in the English translations versus the original Hebrew, words such as suffering are translated suffering, but everywhere else it's called labour or hard work. And so actually we've imposed, even thousands of years ago, our kind of beliefs about what women should and shouldn't do and feel on what we then propagate out. I think it's an enormous problem, because if we think about, the kind of dominant narrative for women who want a good birth experience is that they're in some way, they've got unreasonable expectations, or, they're just they're a little bit spoiled, they're playing up, or they're just a bit hippie. Whereas, Zach, as I was about to meet the love of my life, I don't think it is unreasonable to actually want me not to be traumatized, the love of my life not to be, injured or to spend a long time in ICU. I think it is reasonable to want a good experience. And you've seen women giving birth, right?
Yes, and I have to say it was one of the most amazing experiences of my entire life. And very grateful to have that experience. And there's just something about when the baby starts crying and changes color to pink. It's just such an amazing emotional experience. There's no other way to describe it.
It is amazing. And one of the problems, I think, is that the noises that women typically make is certainly in a hospital where they they definitely have high levels of pain and fear that make everything harder. But the sort of noises that women make, if you do not experience them, certainly if you don't experience them in a physiological way, you assume that is severe pain. But the types of pain that people experience are very, very, very different throughout labour. And certainly the environment really affects how people perceive that. But I think if you look at them and go, gosh, these people are suffering, we can end their suffering in these very nice, humane ways. You again kind of create this narrative where women's voices are not listened to. And I think, as in the Ockeden Report, as in everything, if you're not listening to women and helping them to set up for success, actually, what are you doing?
Mm-hmm. And we've talked a lot about birth, but I wonder, are there other problems that you see in your work to do with women's health, to do with how we've set up the environment in ways which might be damaging or harmful to our health? And what should we do about those?
Mm-hmm. It's a good question. In fact, I'm going to even take a step back further, Zach, and give you a little bit of a broader picture without focusing specifically on women's health, because I think there is a bigger question here. And I think, so I'm the mother of a child with additional physical needs. And that has driven me to learn lots about lots and lots of different areas in biology, in addition to the work that I do. Often I apply what I've learned, but there's certainly a very strong personal motive as well. And I think one of the things that I find that's really interesting is how when you provide the environmental inputs for which we've evolved, even when you've got quite significant pathologies, you can see quite good reversal or remodeling. And so I want to give you just kind of a few snapshots of the sort of things that we think about. So additional physical needs. We talked about sitting on the floor. About 3 years ago, I challenged my partner, who you saw earlier, fixing the sound, to give up chairs for Lent. So we had 40 days without chairs. And after 2 weeks, I was so tired I could barely move. And realising how much movement you outsource to chairs is crazy. So we got rid of chairs in our house. And we've got monkey bars in our lounge. We don't use the stairs to get up to the first floor. We've got a climbing wall. For our children, especially the child with additional needs, they eat hard, tough foods with intact plant structures, and that helps the jaws to develop, because hopefully they won't suffer the pain of the orthodontics that we've suffered through. And actually, again, very much environmental. They're outside for several hours a day, because when you are exposed to natural light at the right circadian rhythms, the equators of your eyes grow to focus what you see at the distances you're looking onto the back of the retina. So there are various things you do to prevent myopia, to prevent short-sightedness. The children sleep on hard surfaces, because actually, as bodies relax and deform and move, that provides all of the stretching that you don't then have to do to a child during the day. So there are so many different aspects to life that we can hack in different ways to provide better growth for children without any differences, and to provide very, very good support and as much environmental help as we can to those with differences. So that's a little bit of an overview. There are a lot of different aspects here that we could talk about. What do you want to talk about?
There was so much in there that, I was kind of thinking, I want to ask about that. But the thing that really interested me was the orthodontics, because I suffered through, a few years of having braces. Are you saying that that's something that I could have avoided if only I had changed, how I was eating? And is that the kind of foods, or is that to do with the cutlery that we're using? I'd love to hear a bit more about what you have to say about that.
Great question. Okay, so let's just go back to quick biology primer. So teeth have evolved from scales. So they are the last remnants of our sharky ancestors that have moved into position in our jaws. Jaw bones themselves are bones, and bones, as you know, react to load. So the tension on different parts of the periosteum causes increased bone growth. And this is where the fundamental problem comes in, because we have a jawbone that adapts to what we do with our mouth, how we breathe, how we chew on one side of things, and we have teeth that do not. And so this is why we've gone from a situation, if you look back at very old skulls, our jaws should have teeth with spaces. We should never need to floss. I know that's one thing that I had a comment on social media. We shouldn't need to floss, because normal saliva flow between teeth should prevent having the sort of niches in the mouth that cause plaque build-up, and that can cause caries. So we should have well-spaced adult teeth in a well-developed jaw. Now, there are quite a lot of different factors that affect the loading of the jaw and therefore its growth. So some of them are around what you do with your mouth when you're moving it, and some of them are around how you hold it when it's still. So if we think about what the body expects, the body expects breastfeeding, prolonged breastfeeding, so from 2+ years. That provides certain very repetitive forces on that jaw, but it also helps children to breathe through their noses. So we want to have a nose that is the air conduit, and we want to have a mouth that is not an air conduit. So we've got breastfeeding.
Sounds very sensible.
Yeah, absolutely. Then the child weans onto different foods. Those foods are not purees. Those foods, some of them are quite hard and quite tough. Some of them are pre-chewed by an adult and given to the child who does not yet have the molars to deal with it. So by the time the child gets the molars, they're used to handling different sorts of tough or small particle structures and swallow them. We're then designed to have a diet in which we quite frequently do a big gape when we're biting. I mean, I can't really show you this on a podcast, but you imagine eating an apple. Big gape, tough foods, pulling stuff off with our teeth. And then chewing, very chewy things. So we've got chewing at the front, we're chewing at the back, we've got biting at the front. And those are the sort of loads in movement. And the loads when your jaw is stationary, our teeth should be basically together. You should have the tongue on the roof of the mouth, which provides force out on the teeth in different directions. And it also provides loading on the bone. That means that the growth of the jaw is generally forward rather than down. So again, your listeners can't see my face, but your listeners will be happy to know that I have a very typical face of a mouth breather, because I had allergic rhinitis and asthma as a child. I was a very atopic child. And that's another component of the jaw problem. When you breathe repeatedly through your mouth, the forces do not help the jaw to grow forward, they help them to grow down. And when the jaw grows down, there are different aspects of your face that change. So firstly, my incisors never meet at the front, so I cannot bite in a straight line. I have actually quite small cheekbones. The change in how my cheekbones have grown has affected my eyes, which is why I have astigmatism. I have quite big eye bags. That's because I don't have cheekbones that keep the skin on my face tauter and prevent that kind of going in under the eye look. And I had to have loads of orthodontic work. So I have a very typical face of a mouth breathing child. So there are.
Well, I wouldn't have picked up on that.
No, we wouldn't have done. But Zach, you look at a couple of research papers, then look at almost everyone you see. You will be able to see either a chin that is lower, or you'll be able to see, if you look from the side, teeth that are recessed rather than fully out. You can tell by looking at people what they ate as a child, almost definitely how they held their mouth as a child, and whether or not they've had orthodontic work. And that's kind of crazy.
Yeah, that is crazy. So it's been a whirlwind tour through a lot of different problems, and there's one question that I want to ask to sort of bring it all together, which is, if you're wanting to work on these problems and look into the scientific evidence base, figure out, what is going on with this relationship between our environments and our bodies. What's the best way to do that? Is it through academia, or is it through the private sector, as you're working in as an innovation consultant? What are the pros and cons as you see them?
It's a very good question. I think one of the things that a lot of your listeners will be medical professionals, I guess, and my listeners will probably be veterinary. Our discipline has made it, we have a very good foundation for understanding biology and tying stuff in. I think with vets generally, we sort of have to think about evolution and function a little bit more than do medics, because we see so many different types of animals. We have to work out why things are the way they are. But there's a fundamental underpinning of how bodies work. On top of that, in terms of learning more, there are increasingly some popular science books dealing with different areas of this topic. But I think the big thing to do is just get in the habit of asking why things are failing, and not just how. And also not just from an individual perspective, but if something's happening to a lot of people, what is it? Why do we think it might be happening in a greater level too? So academia typically helps you to answer small questions and then to get further and further into those small questions. It's pretty hard to be holistic. I think some of the most impressive people that I see who have done this in an area such as osteoarthritis are visionary medics who have said, look, folks, wake up, this is what is happening. So I think look for the questions, come up with hypotheses and test your hypotheses in the literature. That's kind of the best way of doing it. Is there evidence? If this is the case, then this is what I should be seeing, the evidence. Is this happening? Oh, okay. How does this help me to think differently? What is the next question? Mm-hmm. And certainly I've seen that. I do it in my work, but the skills that I've learned, I certainly do a lot in my personal life because it's fascinating.
Mm-hmm. And it sounds like it requires kind of a different skill set from academia as well. So if you're trained to research down into specific questions and do studies, that seems to me quite a different skill as opposed to looking at a lot of different fields and saying what evidence is relevant to this question, bearing in mind that all of it might not be exactly the format that you want the evidence to be in, but you've got to do the hard work of saying, well, we'll have that piece of evidence, that probably means this. This is a bit of evidence about another part of the problem, and let's put it all together. And that's what I kind of call critical thinking skills, being able to know how to fit that bigger picture together as almost kind of like a jigsaw. Mm-hmm. But it seems to me that in my life as a junior doctor, you don't really get to use those skills. So I'm very interested in, well, where can you use them?
I think what I would say, and you will know this about critical thinking, the more that you have to do it, the easier it becomes, because it becomes second nature. It's kind of how you see the world. So my advice, if you're interested and you don't have space in your day job, is to start doing it personally, especially with things that directly affect you. So if you're seeing something, or you're seeing something that's affecting your family and friends, then go on your own quests, like try and work it out, practice those skills, and then start applying them as you hopefully get more headspace. I think it should apply to most jobs, really. So eventually, but you're not paid to do it. You might not have time to do it at the beginning, but the skills you develop can be very valuable whatever you do.
And if people want to get in touch with you, Gwen, or hear more about the kind of things that you're sharing about, where should they go? I know that you're also interested in helping people with their rabbits. So...
Yeah, that's my little hobby. That's a little bit I do where I still pretend that I'm actually a vet. I mean, I am still a vet, but yes. So I do. You can find you can find ways to reach me if you have questions about rabbits. But in general, LinkedIn is probably the best way to connect. So just drop me a message.
Okay, that's fantastic. And I always end on this last question of if there's a particular book which touches on some of the questions that we've been thinking about today. What would you recommend for us to go and read?
Great question. I think the one that is probably most likely to be relevant to most of your listeners, I'm going to give you an author name, I'll give you one of her books, but actually she's published a lot of books. She's a biomechanist and mechanobiologist called Katie Bowman. Katie spelt with a Y. And the book that I think is really useful is called Move Your DNA. And it's about how mechanical loads affect body tissues, but written in a very, very engaging way and helping you to see that the body as a whole rather than, all of the different individual parts that we learn at medical school. It sort of really helps to bring everything together.
Yeah. Well, I'll make sure to link that book in the description. Gwen, it's been an absolutely fantastic conversation. So thanks very much for being on the podcast.
You're welcome, Zach. It's been great fun.
Fantastic.
If you're listening to this message, it hopefully means that you've enjoyed this episode of the podcast. Thank you for listening. It's for listeners like you that I'm making this content, and it would be amazing to have your support. The ways that you can support this podcast are leaving positive reviews on social media and subscribing if you're listening to this on YouTube. The more listeners like you who subscribe, the more I'll be able to improve the podcast and make better content for you to listen to. So if you like where this podcast is heading, please consider becoming a subscriber. I'll see you in the next episode.
Okay, how was that?
Yeah. We're still recording. That's fine. Yeah, no, that was really good. I hope that I got a little bit tongue-tied around the birth stuff. I've spent so long reading about it, and then I was like, I'm not doing this justice. Never mind. It's all right.
It's almost that you can over-prepare what you're going to say.
Yeah.
Can't you? But no, I didn't especially notice that, to be honest.
Well, given all your stuff on LinkedIn, I was like, shit, I need to make sure that my arguments are really bloody sound. He's going to be like, that was a terrible argument, Gwen.
Yeah, no, I'm very agreeable. So even if I don't agree with something, I'm usually very polite about it. And I think the worst thing you can do is put people under pressure when they're on a podcast.